Good day, everyone. I will be presenting the topic cerebral aneurysm. These are the learning objectives. Cerebral aneurysm is an abnormal localized dilatation of an artery in the brain, usually caused by a weakened vessel wall. These typically occur near arterial bifurcations, where hemodynamic stress is high and structural support is weaker. Most aneurysms develop in the subarachnoid space, particularly around the base of the brain. Recognizing their location and pathophysiology is key to understanding their potential for rupture and clinical consequences. The majority of cerebral aneurysms are found in the arterial circulation, particularly at the bifurcation point in the circle of Willis. When an aneurysm ruptures, it leads to subarachnoid hemorrhage, which typically presents with a sudden, severe headache, often described as the worst headache of life. This condition carries a high risk, with a mortality rate of up to 45%, underscoring the need for early recognition and urgent management. Unruptured cerebral aneurysms are found in 3 to 5% of the general population, with the highest prevalence in adults between 35 to 60 years. They are more common in females, with a female to male ratio of 3 to 2, although the incidence is roughly equal in those under 40. It is also important to note that multiple aneurysms are seen in 10 to 30% of affected individuals, which can complicate diagnosis and treatment. Cerebral aneurysm has several key anatomical parts. The neck is the base, where the aneurysm connects to the parent artery, and it plays a critical role in determining whether clipping or coiling is feasible. The dome or sac is a balloon-like protrusion and the most rupture-prone area due to its thin, high-tension walls. The wall is made up of weakened vessel layers and often lacks the normal media and elastic lamina, making it structurally fragile. The fundus refers to the distal tip of the dome and is sometimes used interchangeably with dome. Histologically, cerebral aneurysm show key structural weaknesses. The tunical media is often thinned or completely absent, and the internal elastic lamina, which provides vessel integrity, is typically disrupted or missing. While the tunical adventitia tends to remain intact, it may contain fibrin, reflecting prior injury or remodeling. These changes contribute to the aneurysm's fragility and risk of rupture. Classifying cerebral aneurysm is essential as it helps guide diagnosis, treatment decisions, and prognosis. Aneurysms are typically categorized based on several key factors. Morphology, such as examples circular or visible aneurysm, based on size, location within the cerebral vasculature, etiology, and rupture status. Understanding these features ensures a more targeted and effective management approach. These are the different classes of aneurysm based on size. Then the different types based on the location of the circulation, based on morphology, risk factors. This can be classified into non-modifiable and modifiable risk factors. Non-modifiable risk factors play a significant role in the development of cerebral aneurysms. These include a genetic predisposition, especially in patients with 2 or more first-degree relatives affected. Hereditary connective tissue disorders like Ehlers-Danlos, Marfan syndrome, and polycystic kidney disease also increase risk due to vascular fragility. Female sex, especially post-menopausal, increasing age, and certain ethnic or geographic backgrounds, notably in Japan and Finland, are associated with higher incidence. Other factors include congenital vascular abnormalities, such as coarctation of the aorta and the presence of brain arteriovenous malformations. Modifiable risk factors significantly influence both the formation and rupture risk of cerebral aneurysms. Cigarette smoking is one of the strongest risk factors due to its damaging effect on blood vessels. Hypertension increases wall stress, promoting aneurysm growth and rupture. Estrogen deficiency, especially in postmenopausal women, reduces vascular protection. Physical inactivity and hypercholesterolemia also contribute to poor vascular health. Addressing these factors is key in prevention and long-term management. The pathophysiology of intracerebral aneurysm of intracranial aneurysms varies by type, but generally involves progressive wall damage. Circular aneurysms, the most common type, arise from hemodynamic stress that weakens the internal elastic lamina. Turbulent flow causes mechanical fatigue, while inflammation driven by T cells and macrophages further degrades the tunica media. Risk factors like hypertension and smoking speed up this process. Fusiform aneurysms typically result from atherosclerosis, while mycotic aneurysms are due to infectious emboli, often seen in infective endocarditis. The natural history of cerebral aneurysm involves several key stages. Formation often begins at the arterial bifurcations, where chronic hemodynamic stress weakens the vessel wall. Many aneurysms remain clinically silent, discovered only incidentally. Over time, growth may occur, especially in patients with risk factors like hypertension or smoking. Rupture leads to subarachnoid hemorrhage, with the risk increasing for larger or irregularly shaped aneurysms. If untreated, rebleeding may occur in up to 30% of cases, often early, and carries a poor prognosis. Some aneurysms undergo thrombosis, which can lead to ischemic complications, while recanalization, either spontaneous or post-treatment, can increase the risk of delayed rupture or treatment failure. The risk of rupture varies depending on the aneurysm's clinical presentation and characteristics. Symptomatic unruptured aneurysms have a higher annual risk rupture of about 6%, while asymptomatic or incidental aneurysms carry a lower risk of 1 to 2% per year. Factors that increase rupture include larger size, posterior circulation location, prior subarachnoid hemorrhage, presence of a daughter sac, PCOM or ACOM locations, smoking, and younger age. After an initial rupture, the risk of rebleeding is highest early, 2 to 4% in the first 24 hours, and up to 20% within 2 weeks. This underscores the need for prompt treatment in high-risk aneurysm, while small asymptomatic aneurysm require an individualized approach to management. Cerebral aneurysms can present either before rupture or after rupture, and it is important to distinguish these scenarios clinically. Unruptured aneurysms are often found incidentally, but 10 to 20% cause symptoms due to mass effect. Patients may experience headache, cranial nerve palsy, seizures, visual symptoms, or facial pain. Extradural aneurysms, like those in the petrous internal carotid artery, may cause local symptoms such as epistaxis, pulsatile tinnitus, or hearing loss. When a rupture occurs, it typically presents as sudden severe thunderclap headache, sometimes accompanied by loss of consciousness, neck stiffness, nausea, vomiting, cranial nerve deficits. Certain headaches occurring days or weeks prior are seen in up to 43% of cases and may be a missed warning. Trigger for rupture include straining, sex, emotional stress, or nose blowing. Notably, early subarachnoid hemorrhage can be misdiagnosed, especially in patients with mild initial symptoms. Hunt and Hess grades 1 and 2. Grading scale for subarachnoid hemorrhage are essential tools that help clinicians predict outcome, plan treatment, and assess complication risk. They also ensure a standardized language for communication across care teams. The Hunt and Hess scale grades patients from 1 to 5 based on clinical signs like headache severity, loss of consciousness, and neurological deficits. The WFNS scale incorporates the Glasgow Common Scale and presence of motor deficit to stratify severity. Radiologically, the Fisher scale uses CT scan findings to evaluate the amount of subarachnoid blood, which correlates with the risk of vasospasm, a major complication after subarachnoid hemorrhage. This is the Hunt and Hess and WFNS grading with their corresponding survivor rate. This is Fisher's grading with the risk of developing vasospasm, which is one of the complications of ruptured aneurysm. Aneurysms are often discovered incidentally during imaging for other reasons or suspected aneurysm. The diagnostic approach begins with a non-contrast cranial CT, which is highly sensitive, up to 100% within the first 12 hours of rupture, but become less reliable over time. If CT is inconclusive, MRI with sequences like FLAIR, SWI, and GRE can detect subtle bleeds. A lumbar puncture is used if imaging remains non-diagnostic. Persistent bloody CSF or xanthochromia, especially bilirubin after 12 hours suggests subarachnoid hemorrhage, but beware of traumatic taps. For aneurysm detection, CTA and MRA are non-invasive tools. CT is highly specific but less sensitive for small aneurysm. MRA has 95% sensitivity but is less accurate for aneurysm less than 3 millimeter. 3D reconstruction improves both. The gold standard is DSA, which provides detailed morphology and distinguishes aneurysms from anatomical variants like infundibular. However, DSA can rarely miss aneurysms, so-called angionegative cases, and this could resolve as a result of vasospasm, vasothrombosis, hematomal compression, or technical limitations. In such case, repeat DSA after 7 to 14 days is recommended, especially when the hemorrhage pattern suggests aneurysmal origin. 3D rotational angiography, and high-resolution vessel wall MRI can further help detect elusive or dissecting aneurysms. Routine screening for cerebral aneurysms in the general population is not recommended due to low overall prevalence and the risk of overdiagnosis. However, certain high-risk groups benefit from targeted screening, especially individuals with 2 or more first-degree relatives affected by aneurysms or subarachnoid hemorrhage, or those with conditions like autosomal dominant polycystic kidney disease, fibromuscular dysplasia, aortic anomalies, or rare syndromes like microcephalic dwarfism. For these individuals, MROA is the preferred screening tool because it is non-invasive and avoids radiations. CTA, while accurate, involves radiation and contrast risk, so its use more selectively. Screening should be individualized and rescreening intervals determined based on personal or family history to balance risk and benefit effectively. The primary goals in managing cerebral aneurysms are to prevent rupture or rebleeding, relieve symptoms, and reduce complications. Management decisions depend on several factors, including the aneurysmal size, location, morphology, whether it has ruptured, the patient's clinical status, and available institutional expertise. Preventive strategies like controlling hypertension, quitting smoking, addressing other vascular risks are essential. For unruptured aneurysms, an individualized approach is key. Many patients are best managed conservatively with regular imaging and follow-up. In ruptured aneurysms, especially in Hunt's and Heinz grades 1 to 4, early intervention with 72 hours is crucial to reduce the high risk of rebleeding, which carries a mortality of up to 85%. Even for grade 5 patients, more aggressive management is now considered, including EVD placement and definitive aneurysmal treatment. Treatment of cerebral aneurysm centers on 2 main modalities: microsurgical and endovascular approaches. Microsurgical options include clipping, which remains the gold standard for durable occlusion, trapping, often with bypass for complex aneurysms, wrapping, used in fragile or unclippable aneurysms to reinforce the vessel wall. Endovascular options are increasingly preferred due to their minimally invasive nature and include coiling with or without balloon or stent assistance, flow diverters for wide neck or fusible aneurysms, intracircular flow disruptors, and parent vessel occlusion in selected cases. While surgery poses a higher risk, especially in older patients or with posterior circulation aneurysms, endovascular treatment is generally safer with lower morbidity and mortality, making it the preferred approach in many modern centers. Surgical clipping, introduced by Walter Dandy in 1938, involves performing a craniotomy and placing a clip around the aneurysmal neck to isolate it from circulation. It offers definitive exclusion with a low re-rupture rate and is often preferred for wide neck or complex aneurysms. However, it's invasive and this carries surgical risks such as brain manipulation and has a recurrence rate of 1.5%. Endovascular coiling, introduced in the early 1990s, is a minimally invasive alternative. Platinum coils are delivered via catheter into the aneurysm sac to prevent blood flow and rupture. It is associated with better long-term independence, fewer perioperative risk, and is especially suited for posterior circulation aneurysms. Still, coiling has a higher recurrence and rupture rate than clipping and often requires a long-term imaging follow-up. After treatment, patients often require comprehensive rehabilitation, including physical, speech, and occupational therapy to recover function. Preventing complication is key. Deep venous thrombosis are managed with compression devices, mobilization, and anticoagulants. Urinary tract infections are minimized by limiting catheter use, and seizures are monitored and treated as needed. Surveillance imaging with CTA, MRA, DSA is crucial to confirm aneurysms obliteration and detect any reoccurrence or new aneurysm formation during follow-up. Follow-up is tailored based on whether the aneurysm was ruptured and how it was treated. Imaging plays a central role. CTA and MRA are preferred for non-invasive follow-up, but DSA remains the gold standard, especially when planning retreatment or evaluating artifacts from clips or coils. For unruptured, untreated aneurysms, surveillance is based on individual's risk. Imaging is typically repeated at 6 to 12 months, then every 1 to 2 years. Long-term monitoring is important for younger patients and those with a longer life expectancy after treatment. When evaluating a patient with sudden severe headache and suspected subarachnoid hemorrhage or focal neurological deficit, it is important to consider other vascular causes. These include arteriovenous malformations, cavernous malformations, spontaneous intracerebral hemorrhage, ischemic stroke or transient ischemic attack, and pituitary apoplexy. Differentiating between these conditions is crucial as they may mimic aneurysmal rupture but requires different management strategy. The prognosis of ruptured cerebral aneurysm remains poor despite advances in treatment. About 25% die within the first day, and nearly half within 3 months. Even among those treated, mortality can still approach 40%. Key factors influencing outcome include older age, aneurysmal location, presence of vasospasm, comorbidities like hypertension, the patient's neurological status at admission, and the extent of intraventricular hemorrhage, all of which significantly impact recovery and survival. Cerebral aneurysm can lead to significant complications, both before and after rupture. Pre-rupture, they may cause mass effect, cranial nerve pulses, like third nerve pulsing in PCOM aneurysm, and seizures. Post-rupture, the most feared complication is rebleeding, especially within the first 48 hours. Other major concerns include vasospasm, which can cause delayed cerebral ischemia, hydrocephalus, electrolyte disturbances like hyponatremia, cardiac complications, and seizures. Survivors may also suffer long-term cognitive deficits or death, highlighting the importance of early detection and management. In conclusion, cerebral aneurysm poses a serious risk due to their potential to rupture and cause subarachnoid hemorrhage. Early recognition through understanding risk factors, clinical signs, and aneurysmal type is essential. Accurate diagnosis rely on advanced imaging, and management must be individualized, often requiring a multidisciplinary team to decide whether surgical and endovascular options for optimal outcomes. These are the selected references. Thank you for listening.